Assalamu alaikum everyone. I am Dr. Mohammad Tajul Islam Bhuiya, intern doctor of Community Based Medical College Hospital, Bangladesh. It's a pleasure to welcome you all in today's seminar, and the topic of this seminar is regional anesthesia and its recent advancement, which is organized by the Department of Anesthesiology, Community Based Medical College, Bangladesh. The Honorable Chairperson of today's seminar is Dr. Abul Kalam Azad Khan Sir, Associate Professor and Head of the Department of Anesthesiology. Co-chairperson is Dr. Muhammad Ali Siddiqui Sir, Associate Professor of Department of Anesthesiology, and resource person is Dr. Muhammad Masood Hassan Sir, Associate Professor, Department of Anesthesiology, and the speaker is Dr. Mohammad Busharujjaman Sir, Internal Medical Officer, Department of Anesthesiology. Now, I'm humbly requesting to the Honorable Chairperson, please come to the dais and conduct the rest of the session. Thank you, sir.
Thank you, Tajul. Assalamu alaikum. Good morning. আজকের এই সেমিনারে আমাদের কো-চেয়ারম্যান ডাক্তার মোহাম্মদ সৌদিকি স্যারকে আমি রাজশাহীর জন্য অনুরোধ করছি এবং রিসোর্স পারসন ডাক্তার মোহাম্মদ মাসুদ হাসান তাকেও রাজশাহীর জন্য অনুরোধ করছি। সামনে উপস্থিত শ্রদ্ধেয় পরিচালক স্যার, বিভিন্ন বিভাগের অধ্যক্ষ স্যার ও ম্যাডাম এবং বিভাগীয় প্রধান, আমার সহযোগীবৃন্দ, বিজ্ঞানী চিকিৎসকবৃন্দ, সবাইকে আমার এই সেমিনারে শুভেচ্ছা জানাচ্ছি। আজকের সেমিনারে আমাদের বিষয় হচ্ছে রিজিওনাল অ্যানেস্থেসিয়া এন্ড ইটস রিসেন্ট অ্যাডভান্সমেন্ট। আমাদের স্পিকার ডাক্তার মোহাম্মদ বশিরুজ্জামান রাসেল, সে আমাদের CB14 বেসিস স্টুডেন্ট। সে বগুড়া মেডিকেল থেকে পোস্টগ্রাজুয়েট করেছে ডিপ্লোমা ইন অ্যানেস্থেসিয়া। তো রাসেলকে আমরা আহ্বান জানাচ্ছি তার প্রেজেন্টেশন প্রেজেন্ট করার জন্য। রাসেল, আমরা সবাই শুনি।
Thank you, sir. Assalamu alaikum. My respected teachers, senior and junior colleague, welcome you all in today's seminar. The topic is about the regional anesthesia and its recent advancement. Introduction. Regional anesthesia is anesthesia affecting only specific area of body when the patient is conscious, arm, foot or lower extremities insensitive to stimulus of surgery or other instrumentation. Why regional anesthesia? It is safe, reliable technique in patients with risk of cardiac and respiratory complications after general anesthesia. High patient satisfaction, maintain patent airway, decreased blood loss, selective muscle relaxation, decreased incidence of deep venous thrombosis, and cost effective. Types of regional anesthesia. There are mainly three types, that is central or neuraxial anesthesia or block, intravenous regional anesthesia, and peripheral nerve blocks. Among central blocks, there are four subtypes: spinal anesthesia, epidural anesthesia, combined spinal and epidural anesthesia, caudal block. Among peripheral nerve block, there are plexus block and single nerve block. Now discuss about central or neuraxial anesthesia. Spinal, epidural and caudal blocks are known as neuraxial anesthesia. Almost all operations below the neck can be performed under neuraxial anesthesia. Spinal anesthesia. Spinal anesthesia or subarachnoid block is a form of regional anesthesia in which a local anesthetic is injected into the subarachnoid space to provide rapid, profound numbness of the lower half of the body. Picture showing anatomy of subarachnoid space in spinal anesthesia. Position for neuroaxial anesthesia. First of one is sitting position. Common position are sitting positions, and another is lateral decubitus positions. Indication and contraindications of spinal anesthesia. Indications: lower abdominal surgery, inguinal surgery, urogenital surgery, rectal surgery, lower extremity surgery, lumbar spine surgery, and different type of obstetrical and gynecological surgery. Contraindications: there are absolute and relative contraindications. Among absolute contraindications, severe hypovolemia, increased intracranial pressure, infection at injection site, patient refusal, coagulopathy, severe atrial stenosis or mitral stenosis. In relative contraindications, severe spinal deformity, sepsis, uncooperative patient, pre-existing neurological deficit, demyelinating lesions, stenotic valvular heart lesions. Epidural anesthesia. It is a type of regional anesthesia where local anesthetic is injected into epidural space to block nerve impulses and provide analgesia or anesthesia over a specific area of the body. Anatomy of epidural space. Indication of epidural anesthesia. Obstetric indication. Among obstetric indication, there is labor analgesia, normal vaginal delivery to provide pain relief during first and second stage of labor. High risk obstetric conditions like pregnancy-induced hypertension or preeclampsia, cardiac disease in pregnancy like mitral stenosis, cardiomyopathy, and pulmonary hypertension. Surgical indications: lower abdominal, urological, and orthopedic surgeries. Postoperative analgesia in cesarean section patient, thoracotomy, and other major surgeries. Chronic pain management, diagnostic or procedural indication such as epidural blood patch for postdural puncture headache. Picture showing epidural anesthesia. Difference between spinal and epidural anesthesia. Drug dose is larger in epidural anesthesia than spinal anesthesia. Onset of anesthesia approximately 25 to 30 minutes in case of epidural anesthesia and approximately 5 minutes in case of spinal anesthesia. Spine level that can be performed anywhere along the vertebral column in case of epidural anesthesia, and in case of spinal anesthesia, lumbar only below the lumbar to vertebral body. Quality of anesthesia is not good as spinal anesthesia in case of epidural anesthesia. Intraoperative redosing is possible in case of epidural anesthesia because there is epidural catheter that can be placed during operation. Generally, a single shot injection in case of spinal anesthesia. Duration of block is adjustable in case of epidural anesthesia because of placement of epidural catheter. In case of spinal anesthesia, it's brief, usually 2 to 4 hours. Caudal anesthesia. Local anesthetic is injected into the caudal epidural space through the sacral hiatus. Indication: pediatric anesthesia for circumcisions, inguinal hernia repair, orchidopexy, hypospadias repair, perineal surgeries. Diagram showing caudal block. Complications of neuroaxial anesthesia. Complications are immediate and late complications. Among immediate complications, hypotension, bradycardia, nausea and vomiting, high block, total spinal anesthesia, and cardiac arrest. Late complications are postdural puncture headache, that is PDPH, urinary retention, nerve root damage, arachnoiditis, meningitis, anterior spinal artery syndrome, cardiac venous syndrome, transient neurological symptoms. Now I discuss about intravenous visual anesthesia or Bayer's block. The technique of intravenous visual anesthesia or Bayer block was first introduced by German surgeon August Bayer in 1908. In Bayer's block, injecting local anesthetic into venous system of upper or lower extremity that has been exsanguinated by compression or gravity and that has been isolated from central circulation by means of tourniquet. Indications: distal arm or leg surgery, useful for short procedure. Advantages of Bayer's block: technically simple, minimal equipment and rapid onset. Disadvantages: duration may be limited by tolerance of tourniquet pain, and another is toxicity. Now discuss about peripheral nerve block. Among peripheral nerve block, we commonly performed brachial plexus block. That's are interscany block, supraclavicular block, infraclavicular block, and axillary block. Interscany block. Indication: surgery or manipulation of shoulder proximal arm. Limitation: ulnar nerve may be spared, so it's not appropriate for operations below elbow. 20 to 30 ml for anesthesia, volume needed, and 10 ml for analgesia. Picture showing interscany block. Supraclavicular block. Indications: operations on the distal arm, elbow, forearm, and hand. Limitation: shoulder surgeries as it spares the axillary and suprascapular nerve. Volume needed 25 to 30 ml for anesthesia. Diagram showing supraclavicular block. Axillary block. Local anesthetic is injected into axilla around the axillary artery. Indication: forearm, wrist, and hand surgeries. Diagram showing performing axillary block. Complication of brachial plexus block. Common complications are pneumothorax, Horner syndrome, hoarseness of voice, vocal cord paralysis, diaphragm paralysis, recurrent laryngeal nerve block, local anesthetic systemic toxicity, that is last, vascular puncture, bleeding hematoma formation. Other peripheral nerve blocks are wrist block, femoral block, sciatic block, popliteal block, ankle block, serratus anterior block, intercostal block, erectus spinae block, transversus abdominis plane block, quadratus lumborum block, and rectus sheath block. Wrist block. Hand and finger surgeries, especially for carpal tunnel syndrome and other short procedures. Diagram showing wrist block. Femoral nerve block, used for postoperative pain management after knee or hip surgery. Provides pain relief for hip fractures and fracture of the femur or patella. Ankle block, usually used for surgical procedures on the foot and ankle and can provide pain relief for several hours after surgery. Now discuss about recent advancement in visual anesthesia. Ultrasound guided visual anesthesia, that is USGRA, requirements: high resolution portable ultrasound machines, better needle visualization, real-time Doppler for vascular avoidance, automated artificial intelligence assisted sonoanatomy recognition. Use: ultrasound guided nerve block techniques become popular in different site block. Advancement in novel fascial plane block, that's a serratus anterior plane block, transversus thoracic plane block, erectus spinae plane block, quadratus lumborum block, interspace between the popliteal artery and capsule of the knee, that is IPEG block, PENG, that is pericapsular nerve groove block. This innovative visual anesthesia technique involves injecting local anesthetic into the potential spaces between fascial layer to provide targeted pain relief that reduce opioid requirements and reduce Side effect. Common type of fascial plan block with use. Canvas abdominis plan block, that is tab block for abdominal surgery like C section, hernia repair. Fascia iliaca block or PNG block or IPEC blocks for hip fractures, hip replacement or lower limb surgery. Clavipectoral fascial plan block for clavicle fracture pain. Technological advancement in continuous peripheral nerve block, that is CPNB, that is lightweight portable pumps, better catheter design, ultrasound guided catheter placement. This continuous peripheral nerve block is used for extended postoperative anesthesia that enhance recovery after surgery. Use of newer local anesthetic agent and adjuvants. Among them, long-acting formulations like liposomal bupivacaine that extend postoperative pain relief time, reducing opioid requirements and improving recovery. Adjuvants that commonly used, dexmedetomidine, dexamethasone and clonidine. These adjuvants improve block duration and quality. Regional anesthesia in special populations. Used more frequently to avoid airway manipulation, beneficial in severe respiratory disease, patient at high risk for general anesthesia, obstetric anesthesia, COVID or post-COVID patients. Safety enhancement of regional anesthesia. Ultrasound guidance, injection pressure monitoring, sterile technique, proper patient or site check, immediate management of local anesthetic systemic toxicity, advanced training and advanced monitoring. Training and simulation advances, virtual reality and simulation based training, needle tracking simulation tools, global standardization of regional anesthesia curriculum. Why these advances matter? Clinical impact. Better safety and fewer complications. In ultrasound guidance, needle tracking and refined techniques reduce the risk of nerve injury, vascular puncture and systemic toxicity. Improved pain control and less opioid use. Better recovery and shorter hospital stay. Broader applicability. Enhanced resource use and perioperative care. Conclusion. Recent advancements in regional anesthesia have significantly enhanced both patient safety and perioperative outcomes. Innovations such as ultrasound guided techniques, long-acting liposomal local anesthetics, peripheral nerve block with catheter, and novel fascial plan blocks have improved the precision, efficacy, and duration of analgesia while minimizing complications. The integration of technology such as artificial intelligence, assisted imaging, needle tracking systems, and simulation based training has further strengthened the reliability and accessibility of visual techniques across clinical settings. Thank you.